Thank you so much, Christy, and thank you for the opportunity to chat with you all and taking the time over the noon hour to meet and discuss different ways to cope with chronic pain and what we know from the science and research surrounding chronic pain management. And from here, I want to emphasize the strategies that I'll talk about today focus on pain self-management, things that we can do individually to help improve the management of chronic pain symptoms. And so to give a little bit of a background on that and my role within the Pain Rehabilitation Center and my roles that I've had within the health system of addressing difficulties with chronic pain is knowing that chronic pain is a widespread problem. Almost 1 in 3 Americans experience chronic pain each year with significant impacts on the individual, but also society at large. And these rates exceed heart disease, cancer, diabetes combined. And research that was published, I believe it was late last year, showed that in 2016, Americans and their insurance companies spent an estimated $134.5 billion on lower back and neck pain alone. And that's more expenditure than all forms of cancer combined. And so I guess we're all trying to figure out, because of this dilemma of addressing difficulties with chronic pain, how do we better treat and manage pain and allow individuals to live a more fulfilling life and the best quality of life possible? And part of that is the understanding the definitions of pain. Our understanding of pain management is not spending this hour is not sufficient amount of time to discuss all the complexities of understanding pain and acute and chronic pain. But I'm going to try to give us a little bit of a background here before we get started in talking about evidence-based mind-body approaches. And last year, the International Association for the Study of Pain, IASP, revised the definition of pain. Not too much of a big revision, but the definition of as we study and understand pain clinically and from an individual's experience is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And what we feel in our body is not intuitive to think about that emotional aspects and the emotional aspects of pain, but how we respond emotionally and behaviorally can determine the level of pain and suffering individuals have and have around the pain experience. And that's where I come in as a pain psychologist, is understanding that emotional aspect, but a pain psychology is woven into that definition of the sensory and emotional experience. And if we pay more attention to that second half of this definition, we begin to understand ways that we can control the symptoms that we experience or difficulties that individuals have with pain. And again, I want to emphasize the aspect here is to not say that pain is not real. And a lot of individuals that I've worked with or individuals that have experienced chronic pain have heard messages from well-meaning providers, those around them, family members, etc., that their symptoms are not real. And that's simply not true. And I'm hoping to demonstrate why that simply is not true as we talk today. But given this definition here, I'm going to throw up a few poll questions. And these poll questions can serve as a bit of an education check, if you will. So I'm going to launch this poll, and you'll see this in your Zoom window. So go ahead and respond when you can. I'll give a few moments to respond to that. The first question being, true or false, chronic pain is prolonged acute pain? And perhaps the definitions may be unclear, and I'm hoping to provide that definition. I'm looking over here because that's where my numbers are popping up. Got 48 of 59 responding. I'll end that poll for now. So about half of you saying true, half saying false. 47 to 53. The falses take the majority there. Let me pull up another question that I have here. Which of the following contribute to the onset and ongoing difficulties with chronic pain? sleep difficulties, anxiety and depressive symptoms, traumatic experiences, prolonged stress, none of the above, all the above. And I'm seeing a few questions pop up in the Q&A. I'll leave time at the end to address those as we go. I'll wait till we get 80%. 98% saying all the above. And last question here, recommended treatments. Oops, let me pull that up again. Which of the following is a recommended treatment approach for chronic pain? Long-term use of opioid analgesics, vigorous physical activity, changing unhelpful pain-related thoughts, or rubbing and guarding the area of pain. These might be leading questions as a psychologist asking these questions. But my hope is to give some explanation and rationale behind some of the recommendations. So changing unhelpful pain-related thoughts has been primarily the number one response. So looking back here, and my hope as we continue to talk is to give answers to these poll questions. And addressing that as we continue that talk is differences between acute and chronic pain. And these are important distinctions. In fact, we can continue to parse out different forms of pain, and addressing different forms of pain often come with their own recommendations. And I'll talk about how the broad recommendations for addressing chronic pain today, but acute pain is the symptom tells you something is wrong and you need to do something about that. You know, for example, if I put my hand on a stove, my response should be to move my hand away so that I don't burn my hand. And it doesn't take too many learning trials to know I should not put my hand on a stove. Where chronic pain is the symptom has lost its protective value. Pain as a system is meant to protect, and it serves an important function to protect the individual on an acute basis. However, when when pain symptoms progress to chronic pain states, and what's thought to be any range between 3 to 6 months or longer is thought to be chronic pain. The cause can be unclear. It can be caused by a known onset, like an injury, an illness, age-related changes, things like that. However, the ongoing difficulty with that can be caused by different factors, and it tends to represent an overlearned neurological pathway that I'll talk about here. Is where acute pain, there's a known injury. If I break my arm, I know that the structure has been damaged, tissue has been damaged, that accounts for the amount of pain that I experience. For difficulties with chronic pain, and that could be pain head to toe. Examples might be other types of conditions like fibromyalgia, is that aspect of tissue damage being a predictor of how much difficulties or how much pain one experiences, and the difficulties that follow become more complicated. It tends to be the nervous system changes that account for a lot of that. And I'll talk about that as we continue. And coping with chronic pain has tended to be one of coping similarly to acute symptoms, which can be problematic because chronic pain is not just prolonged acute pain. It's more complicated than that. And the complications occur with changes in the individual, changes within the body, and how the pain processing occurs from an emotional and sensation perspective. And when you have acute pain or illness, you can think about what do you do to address that? And thinking about here, a few examples of what you might do when you have an acute pain or illness. And you could throw that, I'll allow you to throw that up in the chat. What are some examples that you might do if there's a cut, an injury, an illness? First aid, medicine, right? Ice, rest, compression. Rice, yes. And so the ibuprofen, physio, massage, treatments are short term. Great. We're all on the same page because that process is you initially rest. With acute pain, acute injuries, you rest. You might withdraw from activities. You might stop using that body part. You take medicine. You might eat more. You might eat less. You ice and you rest, you heal, you get better. Now the frustrating aspect of chronic pain and chronic symptoms is that pattern doesn't always take hold of continuing to utilize these strategies often lead to changes within the nervous system in the long term. And long term, again, more than 6 months or more than the expected healing time for that injury, illness, or condition. And what happens is we start to do this over prolonged periods of time. If we're resting more, if we stop using body parts or avoid movements altogether with that, if we withdraw from activities, individuals tend to feel worse about themselves. Their mood tends to worsen as they isolate for prolonged periods of time. They feel worse about themselves as they're not doing the things that had brought them joy or the things that they enjoy in their life. Deconditioning can occur. And when muscles atrophy or weaken around areas and structures that may have previously been injured or areas in the body that have difficulty with pain, it becomes more likely that painful experiences occur. And often is the case that more medicine doesn't necessarily result in better pain management. And we'll talk about that as we continue. So to emphasize that first true or false question, chronic pain is not simply prolonged, persistent acute pain. Changes within the nervous system occur, and those changes influence the presence of symptoms and what tends to be the number one predictor of difficulties with chronic pain symptoms is what's going on between the ears. And what tends to occur is the brain has overlearned that connection between the sensation aspect of the pain experience sent from the body to the central nervous system to the brain. And what happens is that heightened response and heightened threat response starts to change. It's a typical normative response. Any one of us in similar experiences might develop similar experiences. And that because of that, for example, if I injure my arm, and the message from my arm goes to my spinal cord, to my brain, there's areas of my brain that are mapped to my arm to say there's something going on in your arm. Let's create pain to limit movement, to limit activity. And while the body rests and heals and it gets better. Now, if those messages continue to be sent, that process of bottom up from my arm to my brain can also occur from top down. My brain saying, protect that arm, and sending messages, creating the output of pain. And the emphasis here is all pain is the product of our brain's output. The experience of pain is influenced by the organ between our ears, the brain. And what tends to occur is this process called central sensitization. And this is a process that many patients that I've met with are either unfamiliar with or haven't heard often. And this is the amplification of signals within the body that have been sent to the spinal cord and the brain that elicits a heightened sensitivity to somatic signals or body signals. And that increased sensitivity to oncoming excitatory signals of protection, the pain signals or sensors tend to stay open longer. And what happens is the body creates more of those sensors. And that's why what can happen in the cases of individuals that experience pain in one location that can spread to other locations within the body. And that increased volume of pain signal sensitivity causes other things to be perceived as a threat, where conditions that occur that can occur are related to allodynia and hyperalgesia. So for those that are not familiar, allodynia is things that usually don't cause pain. For example, like a feather rubbed on your hand that normally does not cause pain, causes pain for individuals. That sensitization occurs. And hyperalgesia, where things become more sensitive, or they're more sensitive to different types of sensory experiences like light, and other types of painful experiences as well. The emphasis here is chronic pain tends to be an indication of not only changes within the body, but also changes within the nervous system and central nervous system and the brain. And what typically should happen is when people experience pain, it should be almost like an on switch and an off switch. For example, for acute pain, you rest, you heal, you get better. There's a known trajectory, there's a known path. And eventually, when that happens, the message, even in acute pain circumstances, message is sent from the periphery or outside of the brain and spinal cord. And when the body starts to heal and the brain is said, I'm safe, the off switch turns on. So we don't need to protect as much. For example, if I break my arm, put it in a cast, do all the right things that my medical providers might suggest, like rest, icing appropriately. There might be some pain from time to time over the next 3 to 6 months, but generally after that period of time, I won't have difficulty moving my arm or pain with that action or motion. Now, with chronic pain, when those signals can continue for some reason or another, the system has become set on high. And that ability that off switch to turn on, that's moderated by the brain and moderated by processes that do things with your signals within the body, start to turn off. And what can happen in the cases of chronic pain symptoms is that ability to inhibit or turn off those signals might lose its strength altogether, causing a persistent presence of pain in areas of the body. And so as we talk about what contributes to this, how do we understand this change within the nervous system that can contribute to a system that shouldn't have happened, an on switch that was never turned off? Well, what we know is that there are factors and social experiences that influence the presence of chronic pain symptoms and changes to the nervous system. One major predictor is physical trauma, injury, or infection. There are certain cases where individuals experience physical trauma, injury, or infection, and the presence of symptoms remain. And we could see as we're beginning to understand COVID and COVID long haulers, we're seeing changes within the nervous system and a lot of symptoms that are consistent with chronic pain, but also fatigue. That is a symptom associated with central sensitization or changes within the nervous system that can cause protection to occur when not needed. Another aspect and a big predictor of difficulties with chronic pain later in life are emotional trauma, child abuse, or adverse childhood events. We see the increased likelihood of the presence of chronic pain with individuals that have experienced difficult histories such as that. Spinal injuries, another associated factor of the onset of chronic pain. Also, opioid use more than 30 days. And we'll talk about this here in a second, but often prolonged opioid use can result in increased experiences of pain, and a process called opioid-induced hyperalgesia. Smokers are more likely to experience chronic pain later in life and associated peripheral neuropathy, and we see that with prolonged alcohol use as well. Prolonged stress is another reason, and what's thought to be a process that changes the central nervous system is being bombarded by stress from multiple angles for a long period of time depletes our resources to manage stress. And what happens is that depletion can cause that likelihood to be able to downregulate or decrease one's response to stress through an active relaxation response to lose its strength. And then poor sleep is another predictor of chronic pain symptoms. And factors that can maintain then are a variety of different psychosocial factors can maintain or worsen chronic pain symptoms. One predictor of that I've worked with in my time and as a researcher is focusing on what's called pain catastrophizing. And that's just a fancy way of saying negative pain mindset. When individuals expect painful experiences, when they expect that they're unable to manage their pain symptoms, or they anticipate difficulty with activity, often increases with pain can occur over time. Fear avoidance too. So avoiding activities due to concern that symptoms will worsen can actually contribute to further deconditioning and increase anxiety as one tries to get back to those activities that they might have been doing prior that now have been an exacerbator of pain symptoms. Low mood and depression is often a larger predictor of individuals with chronic pain and anxiety as well. So you can have two individuals with the same physical presentation and medical presentation, but if one is endorsing significant levels of depression and anxiety, they'll often report higher levels of pain than those without depression or anxiety. Poor sleep is another factor that can worsen chronic pain and worsen one's overall well-being. And then other factors that can reinforce pain behaviors. So these are things like guarding and protecting that make sense in the short term with acute pain, can contribute to one's lower confidence to engage in activity in the long term. In the Pain Rehabilitation Center, we often talk about different responses and social responses that can be unhelpful. Social responses where relationships start to change from caring and loving family member to caregiver. And I'll talk about that here in a second. But the emphasis here is if the body can change in a way that it becomes more sensitive to the signals that are being sent and create that output of pain more regularly and more easily, it tends to be indicative of changes on a cellular level. And neurons change, the connections change from the area of pain to the brain and vice versa. And the brain and body has gotten too good at creating that pain output. And the emphasis here, and the good news is, we start to rewire that. And there's emphasis here of self-management strategies that can help rewire and reduce picking up danger signals within the body and letting new healing pathways occur. And I like to think about this kind of like this picture of the woods is if the body has gotten too good to create, gotten too good at creating the pain experience through connections from the brain all the way to the area of pain, we have to create new outputs and new connections that can reduce the impact of those connections that have been overlearned. And it takes a complicated process and a coordinated process as well. And the first question that I often receive, well, how can we just get rid of it? Are there medications for this? And what we see is that typical recommendations that can help somewhat, part of the picture, can be things like tricyclic antidepressants, SNRI antidepressants can be also useful. And these medications are labeled as antidepressants because that's what typically, when these medications have been researched, what the primary focus was on depression. But we see that these medications that work on depression also tend to be effective in reducing the impact of signals as they reach the brain, and decreasing the impact of those symptoms as an output of pain. So we see decreases in pain with the use of those medications, but also other types of anti-epileptic drugs like gabapentin or pregabalin is often promoted first. What tends to be less effective in the long run are opioids. And opioid use over time can make the brain more sensitive to pain and start to anticipate signals and create connections and overproduction of pain. And I'm not here to say that all opioids are bad. And there's circumstances where opioids can be useful. For example, in most circumstances throughout the world, opioids are used in palliative care or cancer care circumstances. When it's non-cancer related chronic pain, opioids are often prescribed but not recommended. For example, opioids are not necessarily recommended for long-term use with low back pain or fibromyalgia, and these are often conditions that are prescribed. So the emphasis is if the process of interventional techniques haven't resulted in incremental benefit of pain symptoms or decreases in pain symptoms and benefit in one's life, coordinating best practices in a lot of different domains is important because the brain, there's no one pain area of the brain. And these other aspects that can help change the nervous system require focus from a lot of different domains because as that definition noted, pain is a sensory experience, but also an emotional experience. And focusing on both aspects becomes most important in addressing complex chronic pain or chronic pain in general. First way to do that is soothing the central nervous system. Second is changing pain-related thoughts, changing pain behaviors, asking family for support, daily physical activity and stretching, regulating sleep, and healthy whole foods. And I'll talk about each one of these in turn as you think about how it might relate to you or any kind of recommendations that you're looking for in the management of your chronic pain symptoms. The tricky part is also that when individuals experience pain symptoms, it's the individual's experience, that only that individual has their nervous system that has responded to their learning history and their past. And what happens is things that work for some individuals might not work to others based on how the nervous system is wired. And that's how pain is different from one person to another, because pain is the output of that individual's brain. And that, again, I want to highlight, that doesn't mean it's not real. Same way I wouldn't say that when people feel hungry, they say that that's not real. Pain is an output and a process and a complicated, coordinated response from input and output. And we're beginning to understand that a bit better. And some of the first foundational strategies are implementing gradual activity. And what's typically not recommended is going full bore and vigorous activity, but starting with 10 to 15 minutes a day of stretching, which can help strengthen and loosen muscles around areas of pain. And what's typically recommended are full body stretch exercises, gentle yoga, and Tai Chi, staying within yourself as you engage in these movements, utilizing correct posture and ensuring to breathe as one does this. And the recommendation is about 25 to 30 minutes a day of movement of some form. And movement doesn't have to be you're out running, you're out jogging. Movement can be just movements around the home, shifting from one area of the house to another. Any form of movement is better than no form of movement when it comes to managing chronic pain. And so it starts from the ground up to build in that balance and build in that moderated level of activity. And I'll say that if you speak with your providers in the Mayo Clinic Health System or with Mayo Clinic, we have recommendations for the individual. I want to emphasize that when it comes to physical activity and chronic pain, one approach doesn't necessarily work for all, but we have a general approach that can work for all. So to say that if we can best manage or best identify the forms of movement that would be most applicable to strengthen for you as a target, then that might be an approach that your providers might work toward, or as you work with physical therapy or occupational therapy as potential options. And the next focus is addressing and soothing the central nervous system. So one way is to engage in gentle stretching exercises. The other aspect is to counterbalance what can happen when the stress response occurs. And prolonged stress response, or what's called sympathetic nervous system activation, includes physical, emotional, cognitive, and behavioral responses. And when stress is prolonged, it can come with a laundry list of symptoms. I often show this slide here to patients that I work with that have experienced chronic pain from head to toe, fibromyalgia for as few as 6 months all the way to 60 years. And they'll look at this list and go, yeah, when I experience my symptoms, or if I'm stressed, these are a lot of different symptoms that I experience or experiences that I have. And I check off the box here from a physical, emotional, cognitive, and behavioral perspective. And prolonged stress can cause changes within the nervous system too, where if the body is typically responding to stress on a daily basis, there's an active stress response, the sympathetic nervous system, but there's also a parasympathetic response once the stressor goes away to bring the body back down to a baseline or below an overwhelmed state. And what happens is when chronic pain is present in an individual's life, chronic pain is a chronic stressor on the body. And what happens is the body thinks that it has to be in protection mode at all times because of the output of pain persistently, and that stress doesn't resolve. And what can happen is the body's response to stress and that balancing response of relaxation, or the body's relaxation response, loses its strength, or it might go away altogether. And what I hear from individuals is often things that used to not be overwhelming are overwhelming to me now, or things that used to not bother me now. I'm more on edge. And so the emphasis is as the body changes with prolonged stress and the process of changes that occur with chronic pain, we also want to show the body that that balancing response, the relaxation response, is possible. and emphasizing the use of relaxation strategies to counterbalance stress in one's life. So one aspect and why stress is often an important aspect of chronic pain treatment is if we address stress, often those factors that contribute to muscle tension, emotional factors like depression or anxiety or difficulties with concentration and things that come up with difficulties with stress, if we can address that factor and initiate the body's relaxation response, often that's one way to address the chronic pain experience too. And so by initiating the body's active relaxation response through slow diaphragmatic breathing consistently, biofeedback, a way to monitor the body's processes like muscle tension and heart rate. If we can watch that on a computer screen and then actively decrease that with effort, often individuals report better pain management and report less stress. Other techniques like passive or active muscle relaxation or guided visualization or imagery, meditation, yoga, tai chi, all of these techniques initiate the body's relaxation response or parasympathetic activation, which then brings the body's stress response lower. And the emphasis is to get that stress response below that overwhelmed state. And the emphasis from the research says about 30 minutes a day of different practices. And that doesn't have to be, I'm doing it for 30-minute chunks. It could be, I break this up into 5 minutes in the morning, 5 minutes after breakfast, and break that up throughout the day how you would, or it could be 10 minutes 3 times per day. However you want to break up that time, the research says about a dose of 30 minutes is effective. And one of the reasons also is the body changes that occur in the context of pain is individuals with chronic pain tend to breathe more rapidly than non-pain patients. And the assumption being one, changes to the nervous system, but also guarding and protection and grimacing. And that protection aspect can create muscle tension in of itself that makes it harder to obtain a full breath. And so as we see that individuals slow their breath down, they're often able to manage their pain symptoms or stress much better. And there's research looking at mindfulness too. This has been something that's been built up over the last probably decade and a half or so, looking at ways to shift focus from symptoms in the presence of pain and altering the nociceptive process. And nociception is a fancy word for pain signals. So changing pain signals and shifting focus from pain and monitoring from a non-evaluative stance to fully experience whatever sensory event might be present, using moment-to-moment non-evaluative awareness and reduction in what tends to occur is reduction in pain unpleasantness. It might be present, but how can I shift my focus in this moment? This process is easier said than done, and more research is needed, but individuals that tend to utilize mindfulness-based approaches show changes within the brain systems or brain mechanisms that modulate pain. Mindfulness that's used here, that was used in this study, was able to change the individual at a cellular level. As they're able to shift focus from pain, that ability to modulate pain improved. If we think back to that slide with the arrows, the green and red arrows, the green arrows started to come back with ongoing use of this, as relaxation response can help counteract pain and the stress response. And then shifting focus affects the distraction and attention focus or attention aspects of the pain experience. And then this can be done through working with a pain psychologist or therapist. It can be used in different community settings where group-based mindfulness practice is encouraged or offered. And then diving in a little bit about cognitive behavioral therapy. And this is cognitive behavioral therapy is a therapeutic technique and approach focusing on the connection between how thoughts influence emotions and behaviors and vice versa, the connection between those aspects and how that influences pain. And what we tend to see from my research here in the PRC is that thinking and predicting the worst due to pain often contributes to heightened pain symptoms, heightened difficulty shifting focus from pain, Physiologically, it's associated with increased tension and soreness and increased pain-related disability. And this is thought to be a mechanism associated with any form of pain intervention, whether that's acute pain and surgical approaches, but also pain self-management approaches. And maladaptive pain thoughts are thought to be another one of those predictors of the development of chronic pain. So the emphasis, and this is typically done working with a health psychologist or a pain psychologist such as myself, is to turn down the danger signals based on our thoughts. And pain thoughts alarm our brain. So I like to say, if you think it, you bring it. And where certain thoughts might come up initially regarding pain symptoms, like I can't stand this, it's killing me, I can't go on like this, the emphasis is noting what thoughts might be there as in context of pain symptoms, and then turn that volume down on danger just a bit. For example, I don't like it, but I've dealt with worse, or it's bothering me today, so I'll need to adjust my day. These aspects are more realistic. They're more helpful too, as opposed to something like I can't stand this. And two, it's not about sunshine, rainbows, unicorns, everything's perfect. The thoughts on the blue side, the dampening thoughts, acknowledge the difficulty with pain, but take out the strong emotional response that comes with that. Because as we know, going back to that definition of pain, pain and emotion go hand in hand. And what tends to happen is when people are able to challenge negative thoughts related to pain and start to do a little bit more gradually over time, their confidence and self-efficacy to manage pain symptoms improves, and changes within the nervous system occur. And noting that whenever you think, your thalamus is listening, the part of your brain that directs signals, and it's listening for that danger talk. And if danger talk is there and the threat is there related to, if I go to my daughter's sporting event and I can't sit in those chairs, it's going to be miserable. The brain's already priming itself to have difficulty in that moment with frustration, and it primes the nervous system to experience those signals because that process and those signals and connection are already wired and ready to fire. And so what we see is that when individuals participate in actively challenging negative thoughts related to pain, the processing of pain tends to change. And we look at this in terms of brain functioning and fMRIs. And that's just a fancy way of looking at blood flow in the brain when people in motion, if you will. And when individuals are challenging negative thoughts, we see that the process of detecting signals is routed through the thalamus. When symptoms increase and there's higher levels of negative pain related thoughts, there's higher amygdala response. And that's the fear related centers, it's the emotion related centers. Also, memory responses and anticipation of difficulties are often more likely to fire when individuals with chronic pain approach situations. And from there, it connects to the thought centers. And the thought centers determine the level of threat. And if threat level is high, what's more likely to happen is the output of pain. Now, challenging negative thoughts and keeping them more balanced or realistic, or even positive in some cases, changes how that wiring and process of blood flow occurs as individuals have undergone cognitive behavioral therapy. What we see is that what happens with the connections is the initial response goes to the frontal cortex or thinking centers and evaluating how much of a threat is this situation to me. And if decreasing that threat occurs, it changes the output. There's less emotional response and less widespread brain response associated with symptoms. This is one of the aspects that's drawn me to pain psychology and pain self-management is if we can change what our brain is doing in the context of pain symptoms, we can change the output of pain. It's opening up our own medicine box, if you will, internally to address pain symptoms. And again, I want to emphasize, because nervous systems take time to rewire and wire, that it's not an easy process in doing so. And we see these different areas of the brain to emphasize that there's no one pain area of the brain. It's the brain coordinating an output of experience to attempt to protect, but that protection is overstayed its welcome. And what happens with cognitive behavioral therapy is you can directly target areas of the brain that tend to heighten response in the presence of pain symptoms. Thought centers, emotion centers, and sensory centers themselves change their response in the presence of changing thoughts, behaviors, and undergoing typical approaches like physical therapy that might be recommended, or gradual physical activity that might be recommended. And so we will also want to be mindful of different types of responses individuals engage in the context of pain. And I focus a lot on what's called pain or symptom focused behaviors. And these are any responses or actions that let others know or remind you that you're experiencing pain symptoms. And again, function matters here. If I typically experience pain symptoms, for example, and I'm groaning or moaning or guarding, in the short term, that makes sense for acute pain, for example. Research has shown that continuing to engage in those behaviors actually primes the nervous system to experience pain, and it primes a response from the environment. Either individuals around them might jump in and try to engage in more activities or do more tasks for the individual, or you might get a punitive response from the environment, like, oh, that again, or might lead to more withdrawing or isolating on the individual's perspective, which can be unhelpful. So what's typically recommended is to shift those types of behaviors to decrease moaning, groaning, grimacing, moving slowly or limping, rubbing areas or guarding certain areas systematically over time, because doing so has been associated with increased pain symptoms if it's chronic pain and if it's across multiple contexts. And the function of relief has lost its purpose. If individuals aren't receiving any benefit from doing these types of behaviors, then often that warrants addressing or challenging, because, as I noted with the previous slide, that behavior changes biology. And along with that, when changes occur in terms of behaviors, it often changes how others respond to individuals with chronic pain. And so what's often recommended is helpful family responses that shift focus from symptoms. An example might be changing conversations to ask family members or friends or loved ones how to support you, or focus on not asking about pain, but asking about you as a person. Offering distracting activities, encouraging and praising healthy behaviors or gradual improvements in activity, complementing efforts and reminding when times are difficult of prior successes. The social aspect of the pain experience is really important as well. And so that's often why incorporating family members or ensuring that everyone is on the same page within a family unit is really important. And next, as we talked about, increasing physical activity and with the emphasis of gradual increases. So a consistent exercise routine that includes stretching, strengthening, and aerobic conditioning that has been identified from your healthcare provider or physical therapist or other types of providers that can assess levels of physical functioning. And what tends to occur is as individuals gradually engage in activity, it starts to reverse the deconditioning process and reverse the danger signals, because the brain is thinking, well, healthy people exercise, so this must be healthy. Or, I thought I wasn't able to do this, but I gradually went through this exercise routine and I feel a little bit better. That process changes the signals within the body and also changes the nervous system as it responds to those signals. And I'll also emphasize that not everyone is deconditioned that I meet with chronic pains. In some cases, it's about balancing underdoing and overdoing. Underdoing tends to look like individuals that haven't engaged in activity in a long time, and when they try to, they pay for it. The other aspect are those that overdo and they go, go, go. They try to stay ahead of their pain, but the moment they slow down, their symptoms catch up. And so what's typically recommended in terms of activity is finding a good way to moderate levels of activity that balance underdoing, waking up some of those muscles and reconditioning, but not going so far as to fall into a push, crash, and burn cycle that often occurs with individuals that I work with. And a few ways to approach that are different behavioral self-management strategies. One can be identifying what gives you most purpose and meaning. And knowing purpose and meaning can help decrease suffering in the context of pain and painful experiences. And from there, creating and setting SMART goals. And if you aren't aware of what SMART goals are, these are specific, measurable, attainable, relevant, and time-bound. These are things that are small, and SMART goals can be things like, what am I going to accomplish today? All the way to, what am I going to accomplish next year? But creating a systematic path of working toward things that are most important to you and give you meaning. And the other aspect is utilizing what's called time-based pacing. With pain, and when individuals don't experience chronic pain, they can pace however they want. They get that latitude or fortunate enough to do so. Individuals with chronic pain have to be really mindful of how they utilize their time and energy. And what happens is individuals tend to push until they experience pain, and kind of like in this picture here, they overdo. They reach the level of threshold of activity that's too much for them, which then leads to a crash, a pain flare and a crash. They cease activity until they feel it good again, and then they increase activity and push through pain, which leads to an unfortunate crash. Now, time-based pacing is about not pushing through. It's not no pain, no gain. That's not an effective way to manage pain and approach activity. An effective way to approach activity and pain is to gradually increase activity, but also build in times of rest or shifts in posture. And doing so, what can help keep individuals below that activity threshold, and eventually that activity threshold tends to increase. You can think about this as you get used to physical activity or just activities of daily life, as you get used to certain activities, you gain a bit of a tolerance or improvement in engaging in that type of activity. One way that can help with that is maintaining a walking log or some sort of physical activity log that can hold you accountable, but also give you an opportunity to see that progress. And then again, with relaxation techniques built in to help facilitate some of that moderation or balance. So again, the recommendations are developing a scheduled routine of normal activities. It's alternating between light and heavy activities. It's spreading activities throughout the week. If there are things that occur that are big tasks, you might see if you can do that at more of a duration, or break things into smaller steps. Taking breaks, using modifications, and physically change the way that you might approach an activity. For example, if it's bending over while doing the dishes or that's difficult, you might consider making sure that you keep a stool or a chair handy, or making sure that as you do that, there are different tools or different types of modifications that you can use to help complete that task. And not viewing yourself as a failure or as lower confidence to do that because you're modifying. The emphasis is doing something is better than nothing in terms of activity and managing chronic pain. And often that helps individuals feel more fulfilled. And another way is to keep a planner and schedule in activities like recreation or walking or meditation or mindfulness or different social events, maintaining a consistent bedtime schedule. All of this can be really helpful to keep one on the right track in terms of addressing their symptoms. That structured routine can provide opportunities to use self-management skills in the context of the difficulties with pain. And as we talk about gradual approaches, knowing what's a danger zone or a non-danger zone, and to gradually increase. For example, if I want to walk more and I've had difficulties with walking because of my pain symptoms, I might first identify what's an amount of walking that isn't too difficult for me. And I know that about 5 minutes isn't difficult. But if I walk 15 minutes, that's going to raise my pain to an 8 or a 10. It's going to be difficult to do that at that point. I'll feel like I'm going to push and crash and burn. But my goal is to be able to do a 30-minute walk with my family. I wouldn't start then and say, okay, let's start with 30 minutes and go from there. I wouldn't even start at 15 minutes. You might start with just a bit above that no danger zone, 8 minutes, walking despite how you feel. And this is the tricky aspect, is on a good day or bad day, utilizing these dangers or the safe zone to make sure that you're not approaching that danger zone. And if you can plan ahead of time and, okay, I know I'm generally going to be okay if I do this amount, this is where that gradual push of increasing activity and reconditioning that doesn't fall into that overdoing or overexertion, because we know that 15 minutes is that overexertion mark. So you start with 8 minutes and find a good routine throughout that week. And then you might bump that up to 12 minutes. And as you start to gain confidence and see that, okay, that's a reasonable start, then you get up to 15 minutes, then week 3, then 20 minutes, and gradually work yourself up to 30 minutes despite how you feel. And this is the tricky part, that I also say that moderation's okay and taking a day off is okay. It's more about the consistency in approach of valued or goal related activities that's important in the context of pain management or chronic pain management. And then improving sleep. As I noted, sleep's a big predictor of ongoing difficulties with pain. So this could include establishing regular, relaxing bedtime routine, typically about an hour, hour and a half before bed, limiting screen time, and utilizing all those strategies that we've heard about sleep hygiene, making sure that your clock isn't facing you as you're sleeping. And the goal is to associate your bed with sleep. And if you awaken after 15 to 20 minutes, try to get out of bed as best as you can and do something boring, because odds are if you're laying there in pain or having difficulty not sleeping, you're getting frustrated about that. And getting frustrated and experiencing symptoms when you attempt to sleep is not going to help you sleep better. What often occurs is more arousal of the body, and the body doesn't naturally fall asleep when it's as aroused with frustration, anxiety, anger, you name it. And so the emphasis is to use that routine, get out of bed and do something boring until the body is sleepy, and then return to bed as best as you can. And in some cases, just having a chair next to your bed where you start to feel sleepy again next to your bed, and then come back to it as reasonable or as possible. Try to nap less than 30 minutes, if at all. That steals time from our sleep bank that we have at night. And don't try to sleep, as I noted. Utilizing self-talk and recognizing that if I don't sleep today, I'll get sleep tomorrow eventually. And that's easier said than done. And often the use of working with a health psychologist can be really helpful in addressing. Cognitive behavioral therapy for insomnia is a useful tool and often the gold standard approach to addressing insomnia, but co-occurring insomnia and pain as well. And utilizing relaxation CDs or apps. So one phone application that I might recommend would be CBTI Coach. Nutrition, and I won't share too much about nutrition, but what I will say is that typically the Mayo Clinic recommended approach is one of using less inflammatory foods, and the Mediterranean diet that the Mayo Clinic emphasizes can include some of the easiest ways to follow that approach. Other types of treatments that can work in tandem with pain self-management are hot and cold, weight loss, massage, acupuncture, TENS, assistive devices, virtual reality. I throw this in there because often these approaches are ones that cost money to engage in. The ones that I talked about previously, often there's lower barriers to entry, if you will, and lower barriers in the long term to utilize. But these types of techniques have also been tested and shown to be effective when combined with a lot of different approaches. For the interest of time, I won't dive too much into interdisciplinary pain rehabilitation programming, but for individuals that are significantly impacted by their symptoms and looking to improve functioning, and other approaches have been less effective, an intensive daily program. We have one at the Mayo Clinic in Rochester called the Pain Rehabilitation Center. It's 3 weeks in duration and includes all of those components that I talked about earlier and puts it all together. But that doesn't mean that that's not possible elsewhere. Utilizing your medical team where you live and finding the best way to approach these different types of best recommendations for pain self-management can be really useful as well. So an example pain care plan includes addressing pain from a lot of different angles. One is it could be creating a plan for relaxation, physical activity, stretching, watching your pain language, meaning addressing what you say or what you think when you experience difficulties with pain, and providing a more balanced or more adaptive thought patterns, reducing pain behaviors, scheduling your pacing activities, utilizing good nutrition, sleep habits, asking a friend to support your health. And a lot of this, I want to emphasize, is easier said than done if I hadn't said that already. But often utilizing your healthcare team to help support you in your health goals and pain related goals can be really a vital tool to help set up this plan to hold one accountable, but also to provide some structure or ideas of how to best apply all of these complex approaches. So I think about this kind of almost like a prescription pad of how can I do this? What can I do? When can I do it? And where can I do all of these different aspects that are best in approaching chronic pain together? Because often what occurs when we address one of these domains or one of these roads, there's other aspects of the pain experience that aren't addressed or missed in some cases. So a good plan includes balancing medications with things like soothing the body, physical reconditioning. In some cases, if mood or anxiety or avoidance is strong, cognitive behavioral therapy might be an option. Increasing social activities. A comprehensive approach tends to work best. So I've got a few minutes left here. Oh, I'm sorry, I pushed into the end of the hour here. Different resources. So Explain Pain is a great resource in terms of pain education and understanding a lot of the concepts that I talked about earlier in the talk. Applying pain management strategies and pain self-management. I would recommend the book Managing Chronic Pain by John Otis, or Managing Pain Before It Manages You by Margaret Cottle. These are good starting points to have conversations with providers, loved ones, etc., to help support you in your pain management goals. Thank you. I've got a few moments for questions that I can take here. I see we've got 7. Have rates, I'll try to answer these, and I'll try to stay a bit longer to ensure that I can address this. Have rates of chronic pain gone up in recent years? If so, why? Not really. It seems to be at about 1/3, 100 million Americans experiencing chronic pain, and those rates have been consistent over the last decade or so. There's been some fluctuation of tens of thousands, but not too much of fluctuation otherwise. And what we see is that within the world, the Americans tend to use more opioids combined than the rest of the world. And also the assumption was, well, do Americans, is there a cultural aspect? Do Americans experience pain at a greater degree than the rest of the world? And that doesn't seem to be the case as well. What about when you have severe neck issues and must be careful with your neck? So often that recommendation would be starting with your care team and say, what are the typical recommendations for activity with neck movements, for example, and supporting what would be best recommended from the care team. And then also being mindful of, if there's concern about movement, are there ways that I can get that question answered by my care team, of knowing, okay, what can I reasonably get back to, or what's the level of range of motion that I can approach. And then also, if there's significant concern, if that's impacting you emotionally, considering speaking with some of our integrated behavioral health or health psychologists, that can be helpful to address some of that. Let's see here. How do I determine whether it's chronic pain? This is overactive protective signals, and when it is a physical ailment, new pulled muscle, neuropathy, etc. That's a great question. And I'll emphasize that neuropathy can be part of a chronic pain condition as well. Part of the difficulty is understanding that difference between acute and chronic. Typically, chronic pain, if we think about the timing, right? Typically, if it's lasted longer than that expected healing time, and you're doing less because of it, it might be something that one consider has transitioned into a chronic pain state. When the typical acute approaches of rest, you heal, you get better, or different medical recommendations from your providers haven't provided increased benefit, that might be a time to consider that this has transitioned into a chronic pain state. With chronic pain management, do I ever expect it to go away, or do I get better at accommodating the low level of it? I think it's a little bit of both. I think it makes sense that you'd want it to go away. Pain is unpleasant, and as humans, we are wired to want it to go away. And while you're waiting for it to go away, utilizing strategies that can accommodate for it can help you make better movement toward higher quality of life, and then getting an understanding of what you can do versus something that will have to be adjusted. And there's a lot of grief and loss that comes with chronic pain and chronic pain management as well. And knowing what aspects can be let go of versus some things that can be brought back through consistent use of ways of accommodating. Pain scale for chronic pain as a patient. This has been hard to describe. What are other ways to work with medical staff outside of the 1 to 10 scale? Yes, great question. There's been push for the recent, probably the last half decade or so, to move away from that pain scale. So I work with medical students to ask different questions, because 1 to 10 is difficult, and especially if it's chronic pain. I've heard individuals say that 1 to 10, what's their pain? 1 million. And so to get a better sense of that is to ask, and I've been working with the medical school here to train providers to ask more questions than just the scale. The scale is helpful in terms of understanding how much that impacts the individual, but also asking that question of how much has this impacted you? What are you missing out on? What do you want to do more of that you haven't been doing? And that gives us a better sense of not only the pain signals within the body and the impact of the pain, but then what are your focus? What do we want to, what are some strategies and behavioral strategies that we can start to implement to address that as you work toward better pain management? And what we see is that that number tends to decrease with the use of these strategies. How does one parse out the difference between avoidance that will cause additional injury and fear avoidance? In my case, significant spinal stenosis. That's a tricky question as well, and a great one. Part of that might be working with your providers and knowing what's the typical expectations for range of movement and process with that. And if there's significant anxiety or avoidance that shows up with concern that I would hurt myself, when your providers have said, I think this could be a reasonable amount of activity, but you still find difficulty with that. That's where working with a pain psychologist or a mental health provider that's well-versed in health psychology can be helpful to know what the ways to that might be applying modification or gradual increases to strengthen that area affected by pain. Confused with long-term pain, surviving cancer pain, surgeries heal, but the damage from multiple surgeries, removing parts of organs will flare. Try everything a little bit. No one works, even opioids, injections work the best. My pain team seems unsurprised. The remaining specialists weak. You're right. So you speak to the frustrating stigma that's associated with chronic pain, and the focus here is, as best as we can, recognize there are modifiable factors with pain, but also not putting that on the individual or leaving that to the individual to manage on their own, providing that support and acknowledging that the pain is real and can be generated by more than location, but also brain. I appreciate you. I appreciate the questions. These are fantastic questions. I wish I had time to get to them all. But I have to run here. I have to get back to some of my clinical duties here in the Pain Rehabilitation Center.
Yep. And I can kind of wrap things up again, Dr. Schumann. Thank you so much for being here today. We will be recording, or we are recording the presentation today, and it will be sent out to everyone that is registered. So you should receive that by the end of the week via email. So you will get to review that information. I know we had a lot of questions in the chat about getting to see the information again or reviewing some of that. So that will be sent out. So again, thank you so much for your time, Dr. Schumann, today, and for all of the great questions from all of the attendees. So thank you so much, and have a great day, everyone.
Thank you so much.